The Health Committee is commencing at 10 after lunch. And Chief Joe Bird is going to give the invocation for us.
Father, we come to you this morning to take care of the business of the tribe, and we just thank you for the many wonderful blessings you have bestowed upon us, and just thank you for the families, and thank you for our language, and thank you for the opportunities to work for the people. And just guide and lead us in this meeting, dear Lord, and thank you for everything you do. Amen.
Thank you. Ms. Shelley, we call the roll, please.
Ma'am. Janelle Fulbright.
Present.
Dick Lay.
Here.
Bill England.
Here.
Jack Baker.
Here.
Joe Bird.
Amen.
Julia Coates. Here. Jody Fishinghawk. Here. Meredith Rayleigh. Here. Don Garvin. Hannah Glory Jordan. Tracy Hargis.
Present.
Chuck Hoskin Jr. Lee Keener.
Amen.
Curtis Snell.
Here.
David Thornton.
Amen.
David Walkenstick. Karen Calhoun. We did that before.
Thank you. The chair will entertain a motion for approval of minutes.
Make a motion to be approved.
All in favor?
Aye.
Okay, the minutes are approved. Report, Sarah Service Unit, Mr. George Values.
Good afternoon.
Good afternoon.
Briefly, we've hired another internal medicine doctor. It was a total of 3, still recruiting actively emergency room physicians. We're getting a steady stream of new patients and reactivated patients. We average from 500 to 700 new ones a month. Collections are up.
No, go ahead.
Any questions?
Councilor Keener.
Thank you, Madam Chair. Yes, sir, thank you for your report, George, and I was going to ask you for an update on the MRI, anything, new development there.
I'm waiting on area offices. They gave us a plan to put together project justification documents. It's like 6 or 8 that we have to pull together. I had asked for a timeline from the engineers down there, and they said as soon as we got these documents to them, she could come up with a hard timeline. We came up with a place to put it, not in the courtyard. They took that one away from me, and we're going to set it out kind of behind the hospital, right off of the inpatient hallway.
It will be attached?
It will be attached, but it's going to be in a modular building. It's not going to be built on, it's going to be a modular building.
Okay. That should expedite put it in, right?
That's what I'm told.
Yeah. Okay. And you'll maybe have something to report next month on that, possibly?
I'm hoping, yes.
Okay. Thank you. Thank you, Madam Chair.
Councilor Garvin.
Thank you, Madam Chair. George, I just wondered about the flu situation over there. Is it getting worse or about the same?
We're about the same with everybody else. We're still giving flu shots. We've got flu shots all the way around.
Still got lots of flu shots?
Yes, sir.
Okay. Thank you, Madam Chair.
Councilor Karen Calhoun.
Thank you, Madam Chair. On the MRI report on the building, on the temporary building, what's the lifespan for that temporary building? What do they anticipate? Is that a permanent solution, IHS's perspective, or?
The terminology they use was a temporary. From what I can see, it's going to be there for at least 10 years. That's what I'm told the lifespan of that is expected to be.
And how will they do, if it's a modular building, even though it is adjacent to the building, I assume it's going to be, how are they going to get HVAC and secure power and all that other stuff to it? I mean, I assume that
Yes.
for the engineering work, that is it going to be tied into the hospital's grid, so to speak, on all the systems? Or?
It'll be tied in and attached. So there won't be any open walkway to it. You can go and be contained and covered while you go out to it.
Okay. And then I have some additional questions beyond the MRI about how is it working on the 5% dividend or anything to do with our contract health service from your perspective with Claremore Indian Hospital, IHS contract health services? How's that relationship working, and are we having regular meetings to see if we can help do that better? Because I know we've been inundating you and Connie Davis and Brett Hayes with emails, and I'd like to figure out a different way to not have elected officials, I guess, involved in the process.
Well, as far as I know, the 5% is working pretty seamlessly. There's not a problem with it. I talk to Brett, pretty regularly. Now, a couple of the patients that you guys sent, the names you sent in and asked about, we have already obligated funds for those patients and sent purchase orders to those vendors, those contractors, the hospital or doctor's office in Tulsa. All they have to do is fill out that paperwork and send it in, and they get paid. I don't know why we go through this every so often. They don't fill it out and send it in. But the money's obligated, and they have purchase orders in hand.
So that is not on the patient side, that's on the vendor side where the PO's been sent that they haven't returned it?
Yes.
Okay.
But I haven't heard, I talk to Brett, usually at least once a month, and I haven't heard of any issues with the flow of Cherokee Nation citizens going through our system into that 5% pool.
Okay. Now, from IHS perspective, have you gotten any feedback or anything? Because I know the Claremore Indian Hospital board, through your work, that gets reported back up to Oklahoma City area about the number of patients denied or deferred or approved. So how do you, once that, if a Cherokee Nation patient is denied or deferred on contract health service from the IHS hospital, then they would be approved hopefully by the 5% on the Cherokee Nation side. How then does that get reported to IHS for that patient?
We only report the approved and denied and deferred from our end. If Cherokee Nation picks those up under the 5%, we don't report that at all. They still go in and report it as denied and deferred.
Okay, very good. Thank you so much, George. We appreciate your work and your staff's work.
Thank you.
Thank you, Madam Chair.
Thank you. Councilor Degolay, you're next.
Thank you, Madam Chair. George, you say Mr. Garvin, asked you about the flu shot.
Yes.
Do you know how many doses you have left, or do they send you so many every month? How does it work?
No, we purchase so many every year, and right now I don't know how many doses actually we have, but we have 20.
Okay, so the next 2 weeks that they're telling us, on the news, that is really the flu season. We got people in the hospitals and dying. I'm sure I could see this rush getting ready to happen to not only you but to our clinics. So you're sure you've got enough? That's what I'm told, yes. And who told you?
The chief of pharmacy.
And so do you have a number of dosages available?
I don't know that.
The MRI building, does it not have to be set in concrete and reinforced concrete or what?
I'm not specifically sure on the specs like that.
And I just wonder if they could do it up through the floor of this modular, or what? When I hear it's going to go in a modular, I can see some shaking and moving.
Well, which is why I've tried tomorrow, as our health board, I've tried to get the engineers and some area office people down to answer those exact questions.
Okay.
Whether they'll be there, I don't know, but I'm trying.
Thank you.
You're welcome.
Thank you.
Any other comments or questions for Mr. Giles? All right, thank you for that good report. Next is Cherokee Nation Health Services, and I think Mrs. Davis has got a severe case of bronchitis, so she's sent her very capable people to be here. Dr. Graham, welcome.
Good to see you all. Good afternoon. Welcome, council. We have a number of things to update you about this week. Some of them requested and others just updates to let you know about. I'm going to start out showing you all a little bit of what we discussed with the Democratic freshman congressional people and their leadership recently. We're going to be doing the same with the Republicans. And I was going to run through this PowerPoint very quickly with you and then give you some updates about what we've been doing to work on Medicaid expansion on behalf of the Cherokee Nation, but also all of Indian country. When we've provided these sort of briefings to people, especially congressional people who can make changes to this, we first go through a little bit about Cherokee Nation because a lot of them don't know a lot about us. And so we went through our vision, mission, a little bit about the history of how Cherokee Nation Health Services got to where we're at today. Talk a little bit about the demographics. I don't think this is new to any of you, but if you would like a copy of this presentation, you're more than welcome. And then we run through a little bit about our 14 county catchment area, or tribal jurisdictional area, and we show them that over time we've tried to develop either clinics or hospitals around our tribal jurisdictional area such that no one has to travel more than 30 minutes to get care, and that we're trying to equalize the level of care, with the exception of course, you get higher level of care in a hospital. Yes?
Did you print these off for us?
I don't know if they're printed or not. If you don't have them, then I'm guessing they're not. We'll get you a copy.
Could you just forward them to Shelley or Gail?
Sure.
They could put them on.
Would you like them now or before?
Yeah, I kind of like it when you do your presentation. Are you going to do another one? Does this have to do with the comparative studies and all this?
We'll be doing one on provider compensation after this. Dr. Montgomery will. You have that one already here?
No.
Okay.
Just make sure you have. Thank you.
It's on here. She needs the flash drive. You want me to finish? I was going to finish this one up real quick, and then I'll pull it out, give it to her, and just speak about the things we're doing since this presentation. We've talked about what we want to advocate for with them, and this one was, again, directed at congressional people from the state of Oklahoma. We talked about the growth in our system, our budget growth, and then we went through and just showed them pictures and gave them a general scope of services of what we're doing at each of our facilities, so that they would have some familiarity with what our facilities look like and the scope of services that are there. And again, I believe most, if not all of you, have seen these slides from health before, but it was something that we left in their hands. Then we went through our programs with them too, to let them know kind of the broad scope of our program, that we just don't have clinics only. And then this is where we started focusing to discuss with them on what our challenges are. The fact that our clinics, with the exception of the recently built ones, are aging, that they're over capacity, that in some locations we're having providers not have enough space to most effectively and efficiently deliver care. The fact that we're rural in nature, and due to that rurality, it makes it a little more difficult in recruiting primary care providers and specialists, because many specialists are not available in rural areas. We talked about how much we were referring care out. One of the, as you all know, one of the interesting things about our health system is that not only are we a huge economic driver for the towns that we're in, because of the people we employ and things like that, but we put millions and millions of dollars into the private health care sector marketplace. And we always like congressional people to understand that too, that wherever they might be from, if one of our clinics is close, there's a likelihood that we're helping to stimulate the local private sector medical economy as well. We talked to them about the number of our patients that are uninsured. And then that last statement led right into talking with them about Medicaid expansion in the state. The legislature was out of session whenever Governor Fallon made the announcement she made two major announcements around the Affordable Care Act. One of them that the state would not have a state-based health insurance exchange, and that as of now at least we will be working off something called a federally facilitated exchange. And then also that she was not planning on accepting the monies that were offered under the Affordable Care Act to do a Medicaid expansion the way it's spelled out in the Affordable Care Act. She has said that she would like to do something that is Oklahoma homegrown and specific, and I suspect that they may try to get some of those dollars that were made available, but she currently has rejected that for the state of Oklahoma. They are going to develop a plan, and we've told the governor's staff that we want to have involvement in the development of that, as have other tribes. The governor's staff was at a meeting with us recently, and they reported that it was somebody from the state health care authority, the Medicaid office, that having insurance only impacts 10% of your health status, and that they wanted to work on more than just insurance. Yes, sir.
That percentage strikes me as absurd, but I'm no expert. Do you think that experts would disagree with this idea that access to health care, because you have health insurance, only affects 10% of your health? Do you think that's subject for debate?
I suspect that it is, yes.
How many millions of dollars has the governor, well, she turned down millions before, but in this particular round of turning down Medicaid money, how many millions of dollars are we talking about she's turning down? Because the federal government is going to pick up something on the order of 80 to 90% of the cost of the expansion over the next
For the first 3 years, it's basically, I say it's free to the state. The state does not have to provide its match for the first 3 years, but there is an administrative cost to the state. And the meeting we were at, they'd estimated that to be around $11 million a year. And I'm trying to remember the numbers. That it was between 288 and maybe $388 million a year that we were giving up as a state, and that's not just for Indian country, that's for the entire state population that would have become Medicaid eligible had they accepted that.
And so not only are folks not going to get covered because the governor's turning down this money, they'll in fact fall into that crater where they are in fact obliged to get health insurance under this new law, and the idea would be that Medicaid would be there to help them if they didn't make enough to do it. And now they're going to fall through the cracks. Any details from the governor's office about how she's going to use existing funds to attack this problem?
They've said what they want to do is to develop a state-specific plan. They want to be innovative. They want to. That last little book came from the state health department and the health care authority. They want to focus on healthy behaviors as opposed to just insurance only. And so whenever we met with those groups, we met with the state health department and the health care authority. At that time, I think we met in December. The governor made the announcement. I don't remember the exact dates, late November-ish or sometime in that time frame. So really they had only known about it, these people that we met with. And we met with the highest level people. We met with the chief operating officer from the state health department and what was then the deputy or the vice president of the Oklahoma Health Care Authority, who's now since been selected as the CEO of the Health Care Authority. The person that was CEO has stepped down and retiring shortly. So we met with two very high-level people, and basically what they told us is we only found out about this a few weeks ago, but the governor has charged us to develop a plan on how we're going to deal with this population that could have been eligible for Medicaid if we would have accepted that, them and even more of the state's population. So what we said, and the governor said in her remarks whenever she made the announcements, that they would be working on a plan. And every time we've met with anyone from either of those two departments or the governor's liaison, tribal liaison out of her office, we've said we want to be a part of, we want to be at the table when you develop that plan, so we can make sure that, Indian issues are considered. So all we know is they are going to be working on a plan, and we've told them every chance we get that we want to be a part of it.
Thank you, Dr. Grimm. Thank you, Madam Chair.
So then we talked to the legislators about Medicaid expansion, and I suspect it'll be one of the things that they hear a lot about from their constituents, especially, number one, people that would be eligible for it, but all the hospitals and all the providers that accept funds from this and want to see people have better coverage in our state. I suspect we'll be talking to them. When you asked about could people argue that 10% number, Counselor, here's another one, a study that shows Medicaid coverage improves health outcomes. So, yeah, it's one of those things that that you can talk about. Different studies will show different things, and let me just run through this. And you'll have this. So let me tell you a little bit about what we're doing right now. And then, Amy, do you want to take this and get copies of both of the presentations for them? Since that particular meeting, we have met with both the Oklahoma Health Care Authority and the State Department of Health. And we are becoming, in fact, we've sent one of our staff members today to Oklahoma City to become a member of a coalition of organizations that are forming to work on reapproaching the governor's office about Medicaid expansion. We first would like to help all of the state's population to become part of this by, asking the governor to reconsider. But the other thing that we're doing is, if in fact the governor's not going to reconsider that, one of the things that tribes have gotten together to do is we are working with a consultant who's been working with the state of Alaska and came down and spoke with tribes in December. And we are going to be charging him to help develop a white paper, if you will, for us on a Medicaid Indian-only expansion. And both the Oklahoma Health Care Authority and the governor's office have said they would at least be willing to look at what we propose and see if it's something that they might feasibly be willing to take forward. As you know, the big benefit about doing something like that in Indian country is there is no cost to the state. The first 3 years of this one, there was no cost to the state either, and I failed to continue to answer Councilor Hoskins the rest of the question. It eventually ramps up over the next several years so that the state would be paying 10% and the federal government would be paying 90% on this expanded population. So we're going to first be a part of this coalition, see if we can get it expanded for the whole state, but concurrently we're going to be working with tribes to present something to the Health Care Authority and the governor's office about a tribal-only expansion. And I would also add that there are just a few people, myself and 2 other people, that were asked to brief the governor's office about the Affordable Care Act and its impact on Indian people in the state to help them better understand it. So late this month, I'll be traveling up there. Also present will be the Health Care Authority and the State Department of Health. And so we'll get an opportunity to actually brief them about some of our issues and hopefully start a bigger dialogue about Medicaid expansion and some of the other Affordable Care Act issues that tribes are dealing with. So I'll close that issue off. That's what we're doing on Medicaid expansion, if anyone has any other questions.
Sorry, right in front of me, I was before you down there. So, do we have an estimate on how it would impact Cherokee Nation, like what we would have received under the Affordable Care Act had the federal funding stated up front?
I don't know if we've drafted, I'm looking for our finance person who's out making those copies. I don't know if we ever drafted any documents, but this consultant we're working with is doing some draft calculations for the entire state's tribal population. We estimated that just when we talk about it, that it could eliminate half of the uncovered people right now. So we could use those rough estimates and try to do some calculations. But It's kind of hard to calculate. And we are calculating it more on a statewide basis, like I said, for all Indian tribes. So, but it would be millions of dollars, put it that way.
So you're going to email that to us as well. We don't need hard copies.
Of-
Aren't great, but this presentation.
Yes.
And now, what I didn't see on there was, maybe I missed something, is the possible impact of fiscal cliff and the shutdown of federal government, how that would impact both Cherokee Nation, and I failed to ask George how it might impact Concord Indian Hospital. What does that look like? Our constituents are asking, and I'd like to be able to better describe, because it's been a while since we've been at an impasse.
What they did, primarily when they passed the 2 months' worth of further funding, was they reduced the amount of reductions that we would have to take by 2/9. We were looking at an 8% cut, which for us, that number I can tell you off the top of my head, and I haven't figured out the new number, that number would have been about $11 million if they would have taken 8% away from our Indian Health Service operational budget. Now that has been reduced by 2/9. 2 months over the 9 remaining months is what the paperwork that we've been reading says. So whatever, if you could calculate that for me, engineer.
So, yeah, 11
In your head,
million is 8%, but you said 2/9.
They reduced it by 2/9. They gave us 2 more months' worth of funding over the remaining 9 months of the year. And so all the paperwork I've been seeing has just called it, they've reduced the fiscal cliff effect by 2/9, and I've never seen an actual percentage yet that they've thrown out. So we can look that up for you if you'd like.
Well,
Be
I'm just
easier.
trying to make sure I understand. You're saying 2/9, like
Yes.
a fraction.
Yes, like a fraction.
But it's not 2 months, meaning 2 out of 12 months.
It is our FY12 level. They gave us 2 more months of funding.
But that's somehow interpreted as 2/9?
Or the cut that you'd have to take. How much it reduced the cut you would have to take.
Oh, okay.
And the original cut at 8% for us would have been 11 million. And I can, by next month, if you'd like, we can get you what we would estimate the cut would be to us now. We just haven't figured it out.
So what is our plan? I mean, what does that do to staffing, programs, and services? How's that going to affect our constituent that goes in and is served by our facilities, and how would it affect our staff potentially?
Right now, our projections are that we will be over budget relative to what we've predicted for our third-party coverage. So,
Meaning we expect to make
make
up
more.
with third-party
Yes.
revenues.
Yes, especially now that it's below 11 million. 11 million would have been a stretch to make up only with third-party over what we had budgeted, but we've had 2 good months, and I'm hesitant to, calculate what we're going to make on the rest of the year after just 2 months of collections. But we're watching it very close, and we feel pretty certain that we're going to be over budgeted, so make more money than what we had predicted in our third-party revenue column. So that is where we will do it, and then of course if it's not going to make us break even on whatever those cuts would be, then we'll start looking at what we can do to the programs. But we are not at this point anticipating having to reduce any sorts of services because of what they're talking about. The other thing that I might say too is that every year the federal government, the White House, Centers for Medicare and Medicaid Services, and the Indian Health Service get together and they recalculate the rates of reimbursement for Medicare, Medicaid, both inpatient and outpatient. And for the last 20 years, maybe all except 2 years, those numbers have gone up. And so even though we don't know what that will be till somewhere between April, May, June, July, because what they do is they collect cost reports from all the hospitals, then they calculate what the new rates should be. We are allowed to go back retroactive to January 1 when those become effective. So that later in the year will be kind of a windfall for us too. And I'm going to be surprised if that number goes down, but we'll certainly keep you all informed about that.
Well, I'm kind of concerned, and I know you guys are way bigger expert. I mean, you've been in that driving seat in DC, so I kind of see a perfect storm forming, and I don't feel like at least if we're supposed to be the financial decision makers, I don't feel like we're really having discussions here at this body, and maybe the chair is having the discussions, but I'm concerned. So we've got the Supreme Court case where we've definitely said you're supposed to be paying us more overhead for what we're doing. So there's an increase on the system that has not been funded. We've got a fiscal cliff upon us from the federal government where they're saying we do not have the money, but yet we're going to rely on increased Medicare and Medicaid rates, third-party billing, which is still paid by the federal government. So at the end of the day, it seems like we're at a lot of risk.
You know, I mean, we are watching closely what other tribal health programs are doing and what the federal government is doing. You know, they're being a little bit cautious with their training, travel budgets, if you will. But they've told me when I've asked that question, they're not doing it because of the fiscal cliff issue, but all the press that you read perhaps months ago about GAO and other agencies having these very lavish conferences in resort locations. So the full federal government was asked to sort of step back a little bit on holding meetings and try to be more conscientious about where they do that. And so the best of my knowledge, the federal government within the Indian Health Service is not taking any huge plans to deal with the fiscal cliff issue. I mean, they're telling everybody to be, you know, somewhat cautious, but the fact that we got 2 more months worth of funding also makes the cuts go down percentage-wise. So, but we are watching it closely.
Madam Chair, I had a number of questions, but they're not necessarily to do with this report. Can I save those for letting him finish the report? Any questions around that and come back?
Yes.
Okay. Thank you, Madam Chair. Thank you, Dr. Green.
You're welcome. And I will ask Madam Chair, I had also a facility expansion update to give, and then I was also going to speak about the Jack Brown Center and electronic health record updates, which are under new business. So I can either give that facility expansion update right now or let Dr. Montgomery go into the old business for comparison of healthcare provider salaries, and then I'll do all those at the end, whatever is the will of the group.
Let's go ahead and hear from Dr. Montgomery.
Okay.
Be right back. Let's see if Ms. Sams has that.
While he's doing that, you want me to keep talking or do you want a break?
Keep talking.
Let me give you some dates to put down in your calendars. This will be fairly easy work. On Thursday, January the 31st in Oklahoma City, the Indian Health Service area office has sent out a save the date notice for a tribal consultation. So any of you that might be interested, it's going to be from 9 o'clock until 4 o'clock, Thursday, January 31st. It'll be in the area office, the Oklahoma City area office in their Red Bud conference room. What that particular consultation is going to be about, you've probably heard over time that there are numerous work groups that are going on across the federal government that tribes get asked to participate in. And what they're going to try to do in that consultation is get the tribal representative from each of those work groups, who's the Oklahoma area rep, whoever that happens to be, to come and update any tribal leaders or health staff that are interested in staying abreast of what's going on in those work groups. There is no agenda they've sent out yet, and all we have is the information that I gave you. The other thing is a question to you about a date and a time and a particular meeting. The Oklahoma State Department of Health is going around the state. They're going to have 6 different sessions. They're trying to go closer to the tribes instead of making the tribes all come to Oklahoma City. But they would like to come out, and for us they have proposed Friday, February the 15th. The Oklahoma State Department of Health would come, and the Oklahoma Health Care Authority, the Medicaid agency. And it would be a relatively short session, 9 o'clock till 12. They would give us some updates on what the state's doing around the Affordable Care Act. Then there would be an opportunity at that point, and they'll talk as long or as short as we want. We can set that agenda, so we can have them give some updates about the Affordable Care Act from the state perspective, and then they'll allow us to ask questions or talk to them about issues that we have concerns about. And like I said, they're going to be doing 6 of them around the state. They're proposing that date for us here in Tahlequah. And we wanted to ask you, we just talked with them this morning. We're also talking with our elected tribal leadership in the chief's office to see if they're free. But if that date works, you all think about it and either let us know, or Friday, February the 15th. If that date works, we'll go ahead and try to get a meeting set up. So now that Dr. Montgomery's back, I'll let you
Well,
back.
Dr. Graham, I've got a couple of counselors here in line that I skipped that wanted to
Okay.
ask you a question.
Okay.
Counselor Thornton?
Yes. Dr. Brown, on our third-party collections, do we contract that out to a company to collect that?
No, sir. We essentially run all aspects of it.
It's in-house.
Yes. We do use some third-party components, like to verify insurance. We have a software firm that we contract with to help us verify insurance quickly. But other than that, we pretty much control that cycle from registration, coding, to billing and accounts receivable.
Then the third-party collections don't just involve government, it's private insurance also.
Correct, sir.
Private insurance.
In fact, with Amy here, there she left again. I think for us, our private insurance, a lot of tribes, Medicaid is often the highest collector that they have. I think for us, private insurance, anybody back here want to verify that for me? Nobody wants to stick their neck out, so we can get that for you, the percentages, but our private insurance is very close, if not higher, than our Medicaid collections, too.
I'd like to get that, and I'm sure everybody else would too. Is there any way that you all, as a healthcare facilities, can give us, this council, some kind of scenario on the effect of the Obamacare program?
We're trying to do that each month, if you will. It's a huge bill with a lot of components, and we're taking it as it comes and as pieces of it are getting rolled out. The 2 biggest issues right now are Medicaid expansion, which we just talked about, and then the other one were health insurance exchanges. The state just said they would not do a state-based one, and so we are going to start working with the federal government more closely, because they will be the ones that offer, not only to Indian people, but to all the citizens in the state, a manner to get insurance through an exchange that hopefully will give many options and some more cost-effective options too, both lower-priced ones as well as the Cadillac sort of model. So,
Well, now, is there anything you could put together to let us have it? So, I can't write that fast as you're talking. To send us some kind of scenario on what the problems are and what effect it's going to be on our people, because I'm getting requests from our people. They don't know what effect it's going to be on their health care as far as Cherokee Nation is concerned. Are we going to lower, is it going to affect their care with the Cherokee Nation, or where their scenario? Well, most of them are handicapped or are older people that's asking these questions. So, I'd like to be able to give them some kind of an answer that our health department can stand behind.
Okay. We can try to develop something like that for you. And the other thing we can give you is, which is sometimes subject to change, but we can try to get you the timeline of significant issues of things that roll out under the Affordable Care Act, just so you'll know what's coming next. But we try to keep you abreast of things that are current as they're coming up, and we're working on those. And those are the 2 biggest issues right now. And we just so you know, we field questions out of our office too, and we get those calls from patients, I won't say all the time, but regularly, about how is Obamacare going to affect me? And, we try to answer their specific questions first, because kind of like I just told you, that's a big question with a whole lot of things to it. And for the most part, it's not going to affect their care. I mean, it should be fairly transparent to them. And the biggest thing that's going to affect, non-Indian people is that if you don't get health insurance through your place of work or already purchased it, you're going to be required to purchase it in 2014. Indian people, through that law, were granted an exception to that, and they won't be taxed. That was one of the things that the Supreme Court was looking at, was with the fact that they required people to get insurance, either throw out that whole law or that component of the law. Supreme Court upheld it, and so now, that will happen not to Indian people. They get a pass on that part of it, if you will. So if they don't buy insurance, they're not going to be taxed or penalized. But we all hope they do, so they'll have good and better coverage, and so our systems can also reap the benefits of that to be able to provide more services to them.
Right. The lobbyist or the office that Cherokee Nation has in D.C., to what effect do they help you? Do they help you any at all? Are they still there?
Are you talking about the I'm trying to remember their name.
I think there's 2 or 3 hires.
Yeah, there's a firm that we have been using some up there. Whenever we have needed to use them for things within health, they have stepped up to the plate. We've talked to them, provided them information, and yes, they are helping us, whenever those issues arise. We're not having any sort of regular use of them, but as we need to, when we need to make contact with Washington, we do that.
Pardon me, I just want to change just a little bit on the subject, but those people up there in the Washington D.C. office, they need to report down here on what they're doing by the month to me. They need to report to this council and to the chief's office. So we need to think about that, maybe put that into motion one of these days, real soon. Thank you, sir.
Madam Chair,
I've got some more questions. Can I finish?
Yes.
It's concerning, do you mean, we don't have a D.C. office with Cherokee staff in it anymore?
It's gone.
Right, so you're talking about the hired non-Indian lobbyists?
They're called Cornerstone.
Okay, the Cornerstone.
That's their name,
Is that what you're talking
Cornerstone.
about?
What? Cornerstone?
Is that, I'm trying to get clarification to make sure.
That's what I'm trying to do.
Okay.
Cornerstone is who we've been working with whenever we need to have that sort of help up on Capitol Hill.
Okay, then I've got to the bottom of it. We don't have an office in D.C. anymore.
That's right.
Okay.
Okay.
There's Todd. He might.
Yes, and that was a request that was made at the last rules meeting, and I've forwarded that to Mr. Smith at Cornerstone, and there will be a monthly report at each rules meeting about the activities at Cornerstone and how they're helping us in getting our word out on Capitol Hill in a much better fashion than we have in the past.
We need that. Yeah. Thank you.
Okay, Councilor Garvin had a question for Dr.
One quick question I was going to ask
Yes, sir.
Mr. Graham. You mentioned you presented this to the Democrats, the new ones or all of them?
Both. Well, it was an invitation for the freshmen or new.
My main question is, are you going to do it with the Republicans?
Yes, sir.
And if so, when? And
I don't know that that's been scheduled yet. Does anybody know? Todd, do you know if we've got anything scheduled with the Republican freshmen?
I know the request has been made to Speaker T.W. Shannon, and it will be calendared. Yes, that's high on our priority. Make sure that.
keep us informed on
Okay.
that. Thank you, Madam Chair.
Councilor Dick Lake has got a question.
Thank you, ma'am. As far as the Obamacare, the state turns it down, I guess we're going to do that. Are you saying we, the Indian nations, could pick it up? And do we start paying that ramped-up fee at that time? And is it always a money-positive income to either the state or us?
What we're
20 years left out.
What we're hoping is that that if the governor does not accept a full Medicaid expansion, like I said, there will be groups, this coalition are going to continue to push on that. What we're going to do is approach her about an Indian-only expansion. The state wouldn't pick up any cost for anyone the first 3 years if they would have accepted this, but with Indian people, they don't pay any costs at all. It's 100% pass-through from the federal government. So the state would incur a little bit of cost to run the administrative side of that. When you say it doesn't cost them anything, it costs them a little something, but so we would approach them on that. It always, now on the other hand, if they expand for the state as a whole, and I don't have all the economic studies that are out there, so I better be careful what I say, but the state itself, the state government incurs costs to do this expansion because they do have to ramp up to pay the 10%. And the beneficiaries, are both the people that get the health care and then the hospitals and providers that get the additional revenue for, treating those people, which ultimately is a better thing for the state overall, but it does cost the state government more if they were to pick up this Medicaid expansion. But the ratio of what they have to pay to what would come into the state is the ratio is low. It's not very much cost for all that they would be bringing in, especially the first 3 years.
After that 3 years, is it still money positive to the state or?
It's certainly money positive to the state overall, not necessarily the state government, because then they start having to pay that. It ramps up eventually to 10% of whatever those health care costs are, and then the government or federal government pays 90%.
Do we know how much money that would be?
We have some, that consultant I said that we're working with who's helping draft a paper for tribes so that we can approach the Health Care Authority. There will be some figures in that, and they're pretty startling about how much money you get to bring in versus how much is paid out. And in the first 3 years, it's not much. Not much is paid out by the state, and hundreds of millions come in.
Well, I don't know what the state budget is, but if it equals the state budget, I could see why they might jump back a little bit from that after that third year. But, and the other thing is that you're saying that the Indian nations can go and ask to receive this on our own.
We're going to try that. Arizona has done something like that. And Alaska is trying to do something like that right now, and using the work product of this person that now the Oklahoma tribes are using to consult and draft some things up for us. So, and the State Health Care Authority has said we're willing to take a look at this for you all.
We'll just wait and see. Thank you, ma'am.
Okay, we'll hear from Dr. Montgomery.
Hello, everyone. Councilor Fishing Hawk early last year asked that a study be performed looking at physician compensation, whether an adjustment or raise was in order. You were distributed a copy of that study. By the way, it was conducted by the Office of Recruitment and Retention, and that study was distributed to you last June. Shortly after that was distributed to you, I assumed the role of medical director, and in the last several months, I've used information from that study. I also solicited input from the various providers, the heads of the departments, the heads of the general surgery department, the head of family practice, and asked them to give me their recommendations on whether an adjustment or increase in their salary was warranted. And I asked them to supply me with information that supported this suggested change or suggested increase. Now, the sources of information for this are described in your earlier report. These sources of information include for-profit entities like what's called Merritt-Hawkins, Medical Group Management Association. The Oklahoma Hospital Association conducts an annual survey in which they ask doctors what they're getting paid, and they put that information into a report with suggestions on what average salaries are for providers in different specialties. Again, I reviewed all of that information. I incorporated the input that I received from our own providers, and I came up with this, several people came up with the notions that are included in this final health professional salary schedule adjustment that you have now in front of you. I feel that my job is to answer three fundamental questions. One, is it necessary? Is it needed? Is it important to make an adjustment in provider salaries? Second question is, if we think it's important to adjust our salaries, how much should it be adjusted? And then the third question is, can we afford it? And that's what I'll try to review for you here in these next slides. It's important to point out that this didn't leave anybody out. This was an assessment of provider compensation that went from physicians to mid-level providers, dentists, pharmacists, physical therapists. All groups were evaluated. And the recommendation is to make an adjustment in compensation that averages 11.65%. Some disciplines, the increase would be more, some less. The reason is that, provider salaries all differ. A surgeon makes more than what a pediatrician does. The physical therapist doesn't make what a physician does. So trying to get to that median involved making adjustments that were variable. There wasn't an across-the-board number that would work for all specialties that would get them to that goal of trying to provide them with a salary that approached the median. So again, what I show for you here, though, is the average of 11.65%. This is broken then down by the different specialties, and again, I would emphasize that the differences reflect trying to achieve a median salary, close to median salary, for these different groups, and the starting point for these different groups was different. Not everyone was the same. Not everyone was as close to the median as other groups. And those are the adjustments recommended by specialty. This includes what's called an advanced practice nurse, a certified nurse practitioner, includes midwives, dentists, pharmacists, physical therapists, and physician assistants. This gets to the question of, can we afford it? Based on this recommended adjustment, the cost would be, for the existing staff, $4.5 million. If we were successful in filling all the current vacancies, of which there are 25 vacant positions, cost to fund those salaries would be an additional $900,000 for a total of $5.4 million. Now this is based on the fiscal year beginning in October. So we've already gone through part of the cycle, which we haven't funded. Does that make sense? This adjustment would only be for the remaining few months in our fiscal cycle, which ends up being about $3.6 million for the remaining year. So again, how would we fund it? The cost increase would be $3.6 million for the remaining fiscal year. The Finance Department anticipated this and already budgeted $2.6 million for this increase. So the additional amount that would be needed would be roughly $984,000. So how do we make up this difference? Again, I want to emphasize 2.6 has already been funded in our current budget, and the additional amount that would be needed would be $984,000. Dr. Grimm hinted at this, that our third-party collections already, based on 2 months of collections, we can project that our third-party revenue over budget will be roughly $8 million. So this additional amount will come from this additional third-party revenue. The last slide is just to give you some idea of what this all means. The average, Yes, this is what I wanted. Look at the fine print on the bottom. Based on fiscal year 12 data, a family practice physician, on average, brings in $658,000 in third-party revenue annually. This is the kind of money that hiring a family practitioner will bring to the system. So this is a very brief explanation of where we got to, and I'll entertain any questions. But before I finish, though, I would say that the average practitioner, the average family practitioner, sees anywhere from 21,000 to 22,000 visits a year. Medical services are what I think they are a service, and we need to fund these services to continue to provide the medical staff that supports our health system and provides the service of health care to all of our Cherokee Nation citizens. Any questions?
Well, I've got a comment to make before. We've got several who wanted to ask questions, but thank you for this presentation. It really makes good sense, but I was visiting with Councilor Fishenhoff about it, and we were discussing this, that it's sort of a no-brainer. The more doctors that we recruit, the quicker the better, because they are going to generate seeing all these patients, which is going to equate us having all this third-party revenue coming in. So this is an excellent report, and I agree with it, and I can see where, like, maybe our anesthesiologists are already closer to scale than some of the others, so they wouldn't see this big increase, but I hope that we can follow through with this. And first is Councilor Walkenstick. Got a question?
Governor,
I bet you do.
how many doctors are we short?
As of the last report, 25.
25?
Roughly 10 of those are family practitioners. One of those is a pediatrician, 3 of those are dentists. They're all principally within the primary care areas.
And how long have you been without these doctors?
In the time that I've been here, the vacancy has been of roughly 25, 26, 28 providers since I started in June.
So are we having trouble finding doctors?
Yes.
Or is it, I mean, what do you think the problem is? Is the pay, or that they don't want to move to this area, or what do you think the problem is? It's not finding the doctors.
Well, that's the question.
That's the question.
That is the question. How do we fill those vacancies? And it's due to a combination of things. I think what ends up having someone sign that dotted line. But a new resident, just out of training, just keep in mind, they're burdened with, on average, the average resident, the average medical student, is leaving school with anywhere from $75,000 to $100,000 worth of debt. And so what do you think incents them? What do you think motivates them?
Yeah, money.
It's getting that loan paid.
Yeah.
So it's a combination of things. And out there in the private market, there's lots of carrots. There's signing bonuses. There's adjustments to compensation. If a person is very attractive, the private system, will offer adjustments that will, they're out there. The primary care physicians are going to be in short supply, and we're going to be competing with a very difficult market to find people to come work for us. And we're using other strategies. We always look to IHS for those scholars that are you might say obligated to work for tribal health systems. We have a directed studies program at Cherokee Nation that funds students' medical education, but also obligates them to come work for us. So there are other mechanisms we're looking at, but in the end, I think the thing that most incents someone to work for us is going to be compensation. The other factors such as location, background, all of those things. But
if the increase is, I guess, $4.5 million for the shortage of doctors, and you're saying that we're probably going to have an $8 million increase in third-party collections, can we afford an increase in raises for our positions so that we can make it more competitive, make it an attractive place to fill those vacancies?
Well, again, I want to just clarify that some of this is already budgeted from last year. We already have roughly 2.5 of this budgeted, and the difference that we see that we need to make up at this point is $900,000, which should be easily covered by this increase in third-party revenue. I don't know if that answers your question.
Yeah, I know what you're saying. You're $900,000 short of filling that $4.5 million void to get these doctors to fill these vacancies.
Right.
Okay, that's all. Thank you.
Okay, Councilor Lay, you're next.
Thank you. Those hard-to-fill positions, how are we going to bring those people in?
Increased compensation. We have people inquiring about our health system in Bartlesville, in Veneta, in Tahlequah. There are a variety of people out there that are looking for the opportunity to work for our system, but most of them right now are declining the opportunity, you might say, because our compensation is so much below what the market number is. We have, in the past, used incentives based on locations. And if you looked at some of the provider contracts that are already in place, they have been given an additional amount based on working in certain hard-to-fill areas, hard-to-fill locations. And I would argue that that's a reasonable thing to look at. Does that answer your question?
Well, I'm more concerned, not hard to fill locations, but hard to fill doctors.
Hard to fill doctors,
Surgeons,
okay.
specialty physicians. And we, from what I've gathered by talking to y'all, it's very difficult to do that. We don't have the money. We're right now apparently trying to work out a deal with Tahlequah City to share a couple of specialty doctors.
Yes, sir.
And I got to tell you straight up, Tahlequah City Hospital seems to always get the better end of the deal when we do those things. That's my observation, my opinion only. And I thought maybe we could hire one, they could hire one, we could work something out that way. We seem to want to hire them, share them, and send them to Tahlequah City, and they make all the money. What in the world's going on there?
Well, if I may, I'd like to address that separately, but I will say that part of the specialty physician has to do with volume. You have to have a certain number of cases to justify hiring, and I'm using this as an extreme example, but to hire a brain surgeon. If you don't have a certain number of cases, specific kinds of medical problems that warrant it, it's hard to pay $1 million salary for a brain surgeon when you're only going to have a small number of cases per month that doctor might be seeing. So we're looking at trying to increase those specialty providers, but we have to be careful about it. We have to plan for it. It has to be a combination of, do we have the space for them? Do we have the devices for them to use? And then ultimately it's, can we afford it? So I think the transition to offering these additional forms or kinds of specialty care is something that you do slowly, and you try to do it with planning, so that you're meeting the need, but not spending money unnecessarily. Does that make sense, Mr. Lay?
You still haven't convinced me, but I understand what you're saying.
Okay.
The Directed Studies program.
Yes.
You mentioned it and how wonderful it is. There are a lot of crooks and crannies in that program. I've got people on it. They're not getting their checks on time. They're having to borrow money to pay tuition. Got a call from a young lady this morning. She had to go borrow $12,000 to pay her tuition and live for a while until that check comes in from Directed Studies to Lacey Horn and the treasurer. The time the check gets to her school, OSU, the OSU can't float her. They're not going to float her. So she has to go borrow some money. And so I've asked you all before, Miss Davis, to go over there and try to oil or grease those skids or do something with Directed Studies and the treasurer's office. That treasurer's office sits there on those checks for weeks for some reason. It has to be run around everybody has to sign off on it. These are kids who want to come back to work for us, but if they get mad at us, I don't blame them for saying, to heck with that, I'll go down here to St. John's, because they'll treat me better. I'm really upset with the way this system is working with our Directed Studies. You're bragging on it, and I'm glad we got it, but it's not working as smoothly as it could. And somebody needs to go between health and Directed Studies and figure out what's going wrong. Because by the time Directed Studies gets through monkeying with it, it's got to go to Lacey Horn. She monkeys with it. The check eventually gets churned out over there and sent to the school. It's too late. These people have to borrow the money to pay the tuition.
Mr. Lane, my response is I'll speak to Dr. Morton about it this afternoon or tomorrow morning and see what I can do about it.
Well, I think Ms. Zorn needs to be on that same meeting.
Okay.
She's a slowdown.
All right.
And
Point also.
for the record, just on the check payments, we get those from the programs, okay? The deadline for that is noon on Friday.
I understand your deadline.
We whip those out, and we print checks on Wednesdays, and we print checks on Fridays, and those checks mail. We don't monkey or sit or do anything.
Hey, I've got kids who are smart enough and got enough on the ball to go to medical school and get into medical school, which I don't think is probably very easy. And we make a promise to them that we will take care of them and handle this for them, and all they got to do is go to school and study. They're not going to have to work part-time. They're not going to have to worry about where the check is. And we're not doing it. We're not keeping our promise to them. I don't know where the problem lies totally, but I know by the time it gets through our system, it's late. And they have to go borrow money. And I'm upset with this. And this is the perfect time to talk about this stuff.
We will work on it with Dr. Morton and find out where the disconnect lies.
How am I supposed to get you guys, I find you guys doctors, and you don't help me keep them on the system here? Okay?
Mr. Lay, this is the first
I
I've
hope
been
I
told
made
about
my
this.
point here. I wanted to make the point, and I wanted you to remember this point. Now, the CMB company, we've got a CMB company who goes out and finds medical personnel for the 8 days. I'm asking you all, have you ever thought about using them? I've tried to hook you all up with that company. They're ready, willing, and able to do it, to get people to come in and stay long enough to see if they like us and want to stay. And then you can run them through apparently a slow HR process, which is another one of my pet peeves, but you know, you guys know it too, so I'm not going there. Have we ever used a recruiting company, and how much do they charge us?
I'm going to refer that to Ms. Kilpatrick. I think she's here.
Yes, we're on contract with one. And every time we use a referral firm, I feel like we're a failure. Because if we get the salaries up, we don't have to have them.
Right.
You know, we've got 5 new residents looking at us, watching the salary for it to be increased for them to sign on.
What do they charge us, Ken?
$18,000 per referral.
Okay.
I don't know how they sleep at night.
Here's the deal. I think that we can gather up and go twist Sean Slayton's arm and not charge us nearly as much as that. I think they can do this job for us. Somebody has to go over there physically and sit down with them and figure out how to get it done.
I did call CMB this morning and talk to Guy.
For months, I have been after you folks to do this.
And I told him that we would get back and try to work out a contract.
Okay. Now, the good thing is, when I got here, we were 36 doctors short. You all have worked that down to 25. Thank you. Thank you, Mr. Chair.
All righty. Next is Councilor Karen Calderon.
Thank you. And I didn't realize we had moved out of reports, so I still had additional questions after their initial presentation, still on health committee reports, but I also have questions specifically about this, which I guess is now item 1.
Okay.
I'm not sure where we're at, so just want to make. So if you're going to rely on the $900,000 additional unfunded money needed to just do year 1, I take it to be covered by third-party revenue, but then we heard from Dr. Grimm earlier that we may need all of our third-party revenue to make up for fiscal cliff impact. What gives here? How are we going to do that? We can't take the same bite of the same apple.
Part of that is because, is why I included the final slide. It's just, again, is to emphasize that hiring these vacant positions is going to generate more revenue. Again, an average family practitioner is going to generate $600,000 worth of revenue. Now, I'm going to defer that question on how to balance that out, if I may, Ms. Sams. Is that fair question?
And that's annually $600,000 in revenue, additional per position?
Per family practitioner. Different for general surgeons, be different for a pediatrician.
And you didn't provide the actual pay ranges per position, you only provided percentages. So
Correct.
if we're responsible for the budget, we need actual pay ranges to do back to the envelope, at minimum, to check and verify what we're doing. And I don't see 5, 10, 15, 20-year pay projections and how it's going to impact, because I assume you're still going to move forward with merit raises or cost of living adjustments. we're talking about significant impact.
Right.
We have no idea at this point, I thought from Dr. Grimm's presentation, about what the reality is of increased revenue. And I understand that sheer number of patients we would be able to increase, but if we're going to have federal issues about reimbursement rates and other things are unknowns, there's a trade-off there. And also impact on benefit costs to the tribe.
Right.
There seems to be a lot of missing pieces. I mean, I support regular reviews of our employees to make sure that we are meeting market rates competitively
Right.
for the positions in government. I get that. But if we do it for the healthcare folks, even though they generate third-party revenues, we should be doing it for the entire tribe too. And we're not getting the full picture, so are we going to get some more pieces to this puzzle before we have to make a decision? Because it seems like there's a lot of significant information that we still need.
Ask me your question then one more time. What information, what additional information do you want?
I need the 5, 10, 15, 20-year projections on base salary along with merit and cost of living increases based on this one-time adjustment, I guess.
Mhm.
And also the impact on benefit costs, because you can't just increase somebody's base salary and then not know that benefits would also be impacted. There's an additional cost there. And actual pay ranges. You give us percentages, but you don't give us actual pay ranges, so we have no idea how to check that. I mean, I can't go out to salary.com and you can get a baseline that says what we've done. I can independently say to my constituents, if in the end there's a train wreck financially. I mean, we're also throwing millions of dollars, unknown money, and no plan on facilities and all this other stuff we've got going on. I don't have a sense of fiscal responsibility and having confidence in the vote I would take.
Well, in terms of providing with additional projections, then I would say if you we can give that to you at a later date.
And pay ranges for these different kinds of disciplines of physicians,
Right.
that you provided. You provide percentages, but 100 times 0 is still 0. Is that 100% pay raise on $100,000 or 10% pay raise on it? But what does that look like? What's the pay range for a
Okay.
dentist versus a pediatrician versus
I can provide you with that information.
Thank you.
Councilor Hoskins, you're next.
Thank you, Madam Chair. Dr. Montgomery, thank you for your work on this and the whole department. This is a big step.
Big decision.
So, Madam Chair, thank you, and I'll probably leave some of the councilors out. I know a number of councilors pushed for this, Councilman Lay, Councilman Fishinghoff, to name a few. This is the first time in my 5 years on the council we've really had a dialogue about a problem that's been around for probably as long as we've had a system, which is a healthcare system, which is competitive pay for our physicians. So I'm glad we're to this point. When was the last time we had this kind of a comprehensive pay increase for our physicians, if you know?
I'm told it was 4 to 5 years ago.
4 to 5 years ago. And as far as going forward without a plan, I mean, I see some pretty strong pillars of a plan here. I mean, there's an estimate about how much these folks will bring in on average, and it more than covers what we're going to put out in terms of what is probably a fairly conservative increase in the salary, a significant increase, but conservative given what the private sector pays. So I just don't want folks watching this to think that everybody has the opinion that we're going off willy-nilly here with no plan. I mean, it seems to me like you've got a way to pay for this, and got a way to pay for this on a sustained basis. This is what these folks bring in every year in terms of third-party collections. So,
Yes.
And as far as what action this committee has to take, if I'm hearing you right, you all already within your own budget and within your own authority to increase the salaries can do this. You don't need a vote from this committee, although I suspect if you had a vote, you'd get a vote of confidence on this. But am I correct that you all are poised to implement this, having run the numbers and determined that you can pay for this?
That is correct.
Well, thank you again. Thank you, Madam Chair.
Councilor Fishinghoff.
Yeah, Dr. Montgomery, that's one of the things I wanted to point out, is the same as Councilman Hoskins put it out, is we don't vote on pay raises. The council doesn't. It's none of our business. We're not going to vote on it. So I think that's just a moot point. The other thing I was curious about is when you do implement these raises,
Yes.
how close within the normal are they? I'm kind of curious, because when I looked at the book, and I know you all have looked at it, because I have sat with you all in the committees, and there was no rhyme or no reason I could find out how previously they come up with salaries. Because they was all over the board for whatever you wanted to compare it to. And I'm glad you all took the study together. I'll probably have some more questions that I'll email you, because I don't want to take up as much time in committee. But could you kind of look into breaking that down to me, to compare it to what we are bringing them up around this area?
I can.
And I know we did have some salary.coms. I know we did have some of the sites the hospitals used to compare salaries in that one book.
That's correct.
We had the area, Oklahoma. I think we had even narrowed down to Tahlequah that we compared it to. Because I made fun of the fact that us and Tahlequah together brought down the average, because Hastings was thrown in there with Tahlequah. But if you could get me something like that, I sure would appreciate it.
Okay, I will.
And thank you very much for coming up with this after last month. I really do appreciate it.
Thank you.
Councilor Jordan?
Yes, I think I'm probably echoing the comments of some other counselors that spoke before me, but just very basically, is this change, you're able to find the money within your current budget, is that correct?
Yes, Council.
And you believe it'll bring in, or at least fill some of the 25 vacancies that we have now on the upper end of what we need in health?
Yes.
And you say the last time we gave a raise to that group was 4 to 5 years ago?
Yes.
So since we haven't given them a raise, if you take the average over that 4 or 5 years, it's really amounting to about a 3% or a little better raise. Is that correct?
Roughly.
I don't know how the rest of the council feels, but that seems a very reasonable method by which to increase the ability to hire professionals. If you've got it and you want to spend it that way, I too didn't know that we were going to take a vote on whether to allow you to do this, because I don't think it needs a vote. I think it's within we set you a budget. You have found within this budget where you can do this to increase the likelihood that you will get providers that we need badly in our clinics and hospitals. I don't see where a vote comes in, although like my fellow counselor, I think that you could, if you wanted to, have a vote of confidence. I can tell you I'm very much for that, because I think it was January 8th, you all changed over at Hastings Hospital where everybody is assigned to a doctor.
On empanelment.
And I think they're already doing that at the clinics.
They are.
So certainly we're going to need more doctors.
Yes.
And if we pay them $250 or whatever we're paying them, and they're generating almost $700,000 a year through their visits, it's a win-win for us. Give them a little more money, and let's get more of them, and let's make more money. I mean, that just seems basically the way it should work. I would ask you to consider one additional thing.
Right.
I don't know how this works in the medical area, but on the average, a law student's coming out of school with about $100, $125 in student loans. And I know it's very attractive for them to go to work for the government, so that they, over a number of years, the government repays that loan for them. I think it's anywhere from $6,000 to $12,000 a year that's being repaid for prosecutors on both the state and the federal level. And everyone knows that they don't quite make possibly what people in private practice make. But by repaying that loan, it becomes very attractive for them over, say, if they stay 10 years. It becomes very attractive because they know that they're getting that additional money that's going directly towards that loan. that might be a benefit you want to consider to couple with the raise, and then maybe we can fill these 25 positions. Our people need them. And we need to do whatever is within our reason, within our ability to make this happen. Because it's not just Hastings, the clinic that's going to go in up at Bartlesville is going to be much bigger. They got to have providers. The clinic that just went at Bonita has got to have providers. The clinic that's, the enlargement of the clinic there in Delaware County, the enlargement of the clinic there in Acre County, the redo of the Sequoia County facility, Redbird. All of them are going to need more providers. So we've got to get competitive. And I commend you and your staff and Connie Davis, Dr. Grimm, everyone that was involved in this. I commend each and every one of you for what you have done to find a way to make that happen. Thank you.
Thank you. Thank you very much.
Councilor Keener is next.
Thank you, Madam Chair. Dr. Montgomery, in your report, I think it was for November, you said we were four positions had declined due to their salary package. Or not you maybe, but in the report it said that. And I'll take that as word. So about how many rejections do you get per month, you know?
The person that's on the front line is Kathy Kilpatrick, and I'm going to let her address that.
We're actively, trying to keep a database, but to me, I don't feel like it's all about numbers. We're trying, once we get an interested candidate, we site visit, and then if we do a letter of intent, and if they're coming on board, we have to get the paperwork and get them hired. And so my office has been really short-handed. And so we average about 75 health professionals a year. So, over the declinations, we gave a report, I would think about 7 within the 6 months, usually a month, one a month, that they say, I can speak to you, we had a surgeon, a general surgeon, and a radiologist came for a visit last month. They said, thank you, but no thank you, and they didn't go to any length of why we weren't the priority, but I'm sure it was compensation.
So if I heard you correctly, you said 75 hires of professionals?
Yes.
Healthcare workers, and then...
And that includes our PRN pool. We have some doctors that say, oh, I don't want to work full-time, and they help supplement, they cut out the middleman of the locum agency.
Okay. And then 1 rejection per month?
Yeah,
something like that. Okay.
We're losing 2 providers at Jay, so we're really going to be hurting. Dr. Tatani's leaving, and I want to invite everybody to his going away luncheon, January 25th at noon at the community building. So after 16 years, Tatani's been the rock. Now we're losing the rock. So.
Thank you. So right now we're 25 short.
26.
26. Okay.
We got 1 resignation from Hastings in the ER.
Okay.
Just last Friday.
We want to be exact, and that's that'll be the benchmark from this point forward, I guess. And has this already been implemented? Did this start February 10th, or that was just a target date?
The hope would be to implement it on February 10th.
Okay.
What's the paper?
What's the new what's the new implementation date?
Well, I still think we'd like to see it implemented February 10th. There are some logistical things that would need to be worked out, contractual changes that would need to be worked out, and then just having providers sign the contracts with the change. So we've just got to look at that logistically. But the goal would be to do it by February 10th, if not shortly thereafter.
Okay.
Previous implementation takes 2 to 3 months, but the providers, the effective date, it'll be retro back. So, it will take a while to get all the contracts signed, and but I think what they're going to have to determine is the effective date.
Okay. Thank you.
Thank you.
Thank you, Madam Chair.
Councilor Fraley.
Yes, I just had a couple of quick questions, make sure I'm clear. this $984,846, does that include salary and benefits, IDC costs, and plus support staff that will be needed?
Yes.
Okay. And according to your recruitment plan, this 11.65% is needed, in your opinion, is
Yes.
needed to attract and maintain good health professionals.
To make us competitive.
Okay. That's all I needed.
Okay, Councilor Cherokee on what?
Thank you. So, just to make clear, you're saying that they have not had a cost of living or pay raise for these professionals in the last 5 years at all?
No.
I don't think that's necessarily true.
All right, I'm staying correct.
Excuse me, their contracts allow for an annual increase. It's generally 2% added to their rate of pay, and then any amount above that based on their merit is given to them as a lump sum. It's been 5 years since the scale itself has been evaluated, and a major adjustment like this is occurred.
Okay, so they have been receiving either cost of living raises or merit raises, but it has been 5 years since from a human resources perspective, the industry or the personnel issues have been, the pay rate scale has been evaluated, which that's normal. You don't evaluate typically every year where you're paying a lot of money for stuff and constantly have problems. So some industries will like 10 or 15, but I can see competitiveness in order to respond to these probably every 5. So also in their contracts, do they have a longevity clause? Is that like $20,000 every 5 years that they get to stay? That we just give them a lump sum or an additional $20,000? What does that look like on that longevity clause?
So there is a longevity bonus every 5 years, maximum two bonuses. And it differs by group.
So they're getting a lump sum of like, say, $20,000 every 5 years, and they get that twice over their contract from us already too.
They're here 10 years.
Okay, so is that correct?
10,000 per.
I didn't cite the amount, but I'm just agreeing principle.
The debt was something different.
So there are these lump sum amounts they're getting in these professional areas. And I will need a projection if that changes. Is there a recommended change on that? Because I assume that's part of the compensation.
So just an adjustment to their salary. There was no change, and there's a schedule.
Now, that's the difference between an adjustment to a salary versus a lump sum. When you start compounding a salary, then that's why we need projection.
Right.
You can't just look at year one. And unlike my colleagues, we are responsible for the purse strings. And yes, we do approve a budget, and this is not just about this year.
I understand.
So we may not have a vote this year, but we will be impacting the tribe considerably. We want to do this. That's not the question. We want to do it responsibly. That's the question. So we're going to have a projection. The longevity stuff won't change, but these other things are going to change. And 2% compounded over this much bigger salary range is going to have significant impact over time, I see. Now, do we still have the health foundation that was spoken about? And I thought there was additional recruiters. I'm kind of concerned that we don't have more help on recruiting, because to me, that's really one of the biggest issues. I understand compensation is always an issue, but it seems like to me we should at this committee next month be getting a report on the actual recruitment plan, the lack of staffing there, whether or not the health foundation's moving forward as they indicated at an earlier meeting. And I want a report from Human Resources, who doesn't get in front of us enough, about why they're slow playing all these hires, because I understand that's where we lose a lot of people, and it's not even the base money necessarily.
That's true.
So I would like to understand from them what their response time is next month in terms of responding to candidates and the pools that they give and how they turn it around, because the feedback I've gotten is that they are a big part of the problem. So it doesn't need to be just your folks standing in front of it. There's a responsibility in another area of the tribe that's not being held up. Thank you, Madam Chair.
Councilor Fraley? Oh, pardon me. Councilor Coates.
Thank you. I've just been listening to everything that's been going on, and I'm trying to put this together and put the pieces together and think about it a little bit. And it seems to me that what I'm hearing is two things. That first of all, is increases, and sometimes increases of 10 to 13% approximately for practitioners that are already in our employ is one aspect of it. But the plan to fund this comes primarily from the 25 positions and the additional third-party revenue that will be generated, because the physicians already in our employ are not going to generate additional third-party revenue, presumably. Is that correct? I mean, they're already working
That is correct.
full-time. So we really are counting very, very heavily on the ability to hire into these 25 positions to make up this almost $1 million shortfall in the funding plan here. And I think what I'm hearing is that we don't necessarily have good information from the people who have turned us down as to why they're turning us down. We are presuming some things, but I suspect there could be other reasons as well, and Councilor Watts has brought up one perhaps, but we don't know what the range of things may be. I mean, the undesirability to some people of living in this kind of a rural area may be a very significant factor, and we don't really know that or not.
And how do you change that? How do you address that? And
Yeah, well, the thing is, I think that what I'm suggesting is maybe that we also need to get a little bit of a survey, if we can, possibly. I'm kind of looking past you, Kathy, here, but, you know, to get a little bit of a survey as to, and begin to get some data, because we've basically been sitting in this place for about 8 months of having, at least 8 months since you came on, at least, you know, of being in the same place, of not being able to fill about 25 positions, and yet that seems to be what we're relying on almost completely to make up the $900,000. Am I understanding this?
You are, but I also think, and I didn't mention this, but in some forums I have mentioned this. I think that, you know, there is currently, our providers are expected to work a certain number of days, a certain number of hours a day. There's no productivity incentive. It's linked to compensation. That's the next step that I foresee. I want to say also, not just to productivity. I think there should be links to quality of care. But I think that this compensation will be linked, or a portion of it will be, a portion of a provider's salary should be linked to meeting certain productivity, expectations and quality expectations. And having said that, if you incent providers in the right way, in a meaningful way, you can increase their productivity, which will in turn increase their revenue. And I can't guarantee that revenue will increase by 10%, 20%, 30% over the next 5 years. But I would like to think that if we incorporate that into their compensation, some type of quality and performance incentives, that you could see revenues increase substantially and cover some of these costs. I really do think that will happen.
Did I understand you correctly earlier that that seemed like an enormous number to me, but something like each physician is seeing 21,000, having 21,000 visits a year, or something
You take
like that?
a family practitioner that sees 15 people a day, 5 days a week, you're going to come around 20,000, 22,000 visits a year.
Can we get much more productivity out of them than they already are?
Well, again, if you
Question, that seems like an enormous number already, and if we are concerned about productivity and quality of care, it seems like we'd almost have to see that number seen per day or per year go down a little bit to increase quality of care. So I'm not trying to be argumentative with you here. I'm just trying to understand, what the challenges are. And again, I understand we're not voting on anything today or anything, but I guess I'm a little bit concerned, have some concerns that there's some corners of this that don't seem to be fleshed out very well, and I would just think that hopefully you all would be heading in that direction, to getting some good and better data about how well this might work.
I'd like to say that if you're a patient in a year, I'd like to come back and tell you that our vacancy rate is less. I'd like to come back and say to you, We've implemented some changes in compensation that have as a result of meeting with the providers. And we've asked them what would be meaningful to them in forms of a work schedule and quality measures. And we already have some of those things in place that are being applied inconsistently. Quality measures, you've heard of GIPRA, those are quality measures that have been measured for some time, and those have not necessarily been linked, though, to compensation. And I think it's not unfair to do that because that's what's going on in the private sector. And why shouldn't we implement some of those same changes? Because they're proven methods to improve quality of care and improve productivity. I think I'd like to, again, ask your patience and in a year come back to you and say we've implemented some of these things. Some things may not work well and we'll change them. Others we might succeed with and do a very good job of it.
I would love that. I'd love to hear you come back in a year and say we filled all of those 25 positions, and I hope that works out that way. And I agree that recruiting is such an integral part of all of this that I hope that can really be looked at. And I wish it was. Thank you.
Thank you.
Councilor Thornton?
Yes. Dr. Montgomery?
Yes, sir.
First, I want to tell you, thank you for doing this. I think this council owes you a big thank you. And the first thing is that 14 years ago, we started trying to do this very such thing, and it's been put off because somebody was positive, somebody's negative on it, and it just run a circle is what it's done. And I'm proud that we have a professional like you to do this.
Thank you.
Vacant positions, we're always going to have a vacant position. I don't care what you do, what you say. I'd like to know how many professional positions we have in the system, but you can give that to me later.
Okay.
Some other time. We've always wanted to try, this council has, to bring these salaries up to par. And what you're sitting here telling me today is you're adding, this is going to be an added impact of revenue, but it's going to be an added impact of service. It's going to be an added impact of the capacity of people that we are going to have over the next 5 to 10 years because we're increasing the square footage on what, 5 or 6 clinics and building a new clinic or 2 by increasing the square footage. I know at Redbird we're supposed to increase it 30,000 square feet on the annex. But you hit on it, but just the last subject that come up, and we owe our people a good quality care, of which they're not, I think they're below average now. I think that these people will get a better quality of care and probably above average if we can impact these clinics and impact the doctors. And I want to tell you how much I thank you for doing this. I'm for you to go ahead and implement this. If it has to come to a vote of this council, whether some of them don't want to or some of them do want to, I'd like to see a vote. But anyway, I thank you, sir.
Thank you.
Councilor Fisher-Hawk?
I was about to say, I read my book every month, and I know in health somewhere you all do the recruitment. And I found out where you talk to recruitment on page 11, 12, 13, and 14. You all really started going in depth on it in these last several months. And I appreciate the report that we're getting. I can't imagine it being much more in depth, other than we're getting down to naming names and numbers. But I do appreciate that. And I know we're running out of time, but I would like to ask your recruiters, will this help you recruit people?
It will make a difference, but it's not a big cure. There is a shortage of physicians, just like Dr. Grimm said. We're in the rural area. It's hard to attract doctors that want to come and live in the rural area, bring their families. There's all these obstacles that we have to face. But we've been really fortunate lately. We've got 2 OB/GYNs at Hastings. We've got 2 new surgeons, that came. It's great that we're getting them to come back to the community. But this is going to help. But I don't, I really want to be the leading recruiter, and we have a lot of competitors, and it's going to help by when I go to recruit a physician saying our compensation's in review, it's coming, and 6 months later it's still not there. So this is going to help that I'll have to talk about that now.
I appreciate it, because I'm one of the people that, we talk about jobs here, we talk about education, we talk about health, but if you're not healthy, you cannot go to work, you don't want to go to work. You can't learn good. Health affects every part of your life, whether it's working, caring for your family, getting along with others. It affects every part of everybody's life. And I'm like you, I would rather us be the person, the provider of choice and the ones that people want to go to work for us. And I appreciate y'all's work, and I look forward to seeing some numbers next month. Thank you.
Councilman Thornton?
I would like to see Dr. Grimm get back up. I think we beat this to death. I'm anxious to get these reports that he's got on these clinics.
I've got a question or a comment here on that before we get to
Councilman Light, did I skip you? I'm sorry.
Can I go?
Yeah.
Thank you, Manager. And all I want to say about this to finish this up is, other than who we are, is healthcare is the most important thing we do. It costs money. Sure it does. And as far as profit margins and all that stuff, when you add a doctor, we're going to make more money. That's what I heard today. And I have to equate things so that I can understand that if I've got one cow, I get one calf a year. That's $1,000. If I own 1,000 cows, I get a whole bunch of money a year. Is that analogy good enough? It is? Okay. And I appreciate the health department very much. And I'm going to go ahead and make a motion to give a vote of confidence for this health professional salary schedule adjustment. I'll just make that motion.
Second.
Okay, we have a motion and a second to give the health professionals salary increase a vote of confidence. Do we have any discussion?
Madam Chair, I'm not quite clear why or what we're voting on.
If I may,
Would you repeat your?
Yes, ma'am. Thank you. I heard several people talk about a vote of confidence. We don't have to vote on this as counselors.
No, that's
I've heard
within their
people
jurisdiction.
talk about a vote of confidence on this. And if there's some illegal reason we shouldn't, I understand.
No, just
But like I said, healthcare is the most important thing we do.
one of the
If we
most
can't,
important things.
well, one of them. And if we can't get this done and worked out, we're just spinning our wheels on the initiative of healthcare for my people. My people go, you've been there, my people are in a strip mall in Bartlesville. One doctor, one nurse, small lab. They don't take new patients, haven't for years. They don't have
I understand the need. I'm asking the question, why are we voting on it? Because it's within their jurisdiction.
And I'm giving you the answer, if you'll listen.
I see the Attorney General has risen. Can you give us your opinion on us having a vote of confidence?
Well, as long as everyone's aware that this is an advisory vote on it's just an expression of will in favor of this plan as a council seat, but it has really no precedent value. I just want to make that point.
Okay. All in favor to show a vote of confidence of the new health care provider increase?
In clarification, that's just to say that, yes, they should proceed with reviewing salaries and increasing, because we have no real details, right?
Right. It's just to say that we are in favor of their progress.
No, as I understand it, it's a vote of confidence to say on February 10th, they're going to add money to people's paychecks. It's not to proceed to do more studies. That's already been done. So that's my understanding, and tell me if I'm wrong. But they're planning to implement a program, and if we're going to give them a vote of confidence, it's a vote of confidence to go forward with that program and implement it by February 10th.
Point of order then, that's an actual action on the budget, which is not on the agenda.
No, that's not what we're voting on.
I'm just, the way I interpret what was reinterpreted, so.
Let the Attorney General speak, please.
Yes, again, the power of the executive branch, they can implement this right now. This whole presentation has been an exercise in transparency and information to the tribal council. We've worked with the tribal council, the finance department, the health department. Everyone has worked in making sure that we're all on the same page here. A vote, if the council chooses to take one, is a vote of confidence, of recommendation. It's not a resolution. It's not an act. If at some point that there needs to be a budget mod done towards that, obviously it would come through executive finance and it would be part of a budget modification. But this, as I understand it, is that the council wishes to express its will of support for this plan that health is going to implement as of February 10th. That would be the consensus of the vote.
All in favor of showing support, of goodwill, for them to move forward as a vote of confidence, let it be known by saying aye. Aye. All opposed? Same sign. All right, it is passed. We all show support of confidence.
Thank you all.
Since the hour is about almost 3 o'clock and we went through another meeting's time, I would ask the board or the chair to entertain an idea of adding an hour, maybe starting our meeting at 12 next month and take the rest of the items on the agenda. And then if we have other reports from our health staff, we will have more time to take action on those.
Put that in form of a
I
motion.
put that in form of a motion.
Second. All in favor of moving our rest of the remainder of the business to next month and start an hour earlier? That's what we're voting on here. So, all in favor, let it be known by saying aye. Aye. All opposed?
Aye.
Have 2 opposed.
Take one.
The chair will entertain a motion to adjourn.
Second.
All in favor of adjournment? Aye. We're adjourned next month at 12 o'clock. We will